Hey, it's my pleasure to introduce to you Dr. Angela Thomas, who serves as the Vice President of Healthcare Delivery Research at MedStar Health. She works with a team of healthcare delivery experts to lead, implement, and evaluate data-driven solutions that support policies and programs that improve healthcare in a manner that integrates science with the clinical and operational expertise required to meet patient and community needs. Dr. Thomas ensures that these research activities leverage the collective leadership and unique strengths of MedStar Health and Georgetown University. Dr. Thomas has published and presented both nationally and internationally on research related to urinary incontinence in women, health equity, patient safety, and disparities in maternal and infant mortality. Dr. Thomas is the executive lead for the DC Safe Baby, Safe Moms initiative. She is an adjunct associate professor at Georgetown University in the Department of Health Systems Administration and a faith-based leader in her community. Dr. Thomas received a Bachelor of Science degree in biopsychology and the cognitive sciences from the University of Michigan, and also from the University of Michigan received a Master of Public Health degree in health behavior and health education. She received her Master of Business Administration from the Walsh College of Accountants and Business Administration, and her Doctor of Public Health and Advanced Practice Leadership in Public Health from the University of South Florida. So again, very pleased to introduce to you Dr. Thomas.
Thanks for the introduction, Mary Ann, and thank you to the entire GHUCCTS team for the invitation to present this afternoon. And so I'm just going to go ahead and get into the presentation. As mentioned, I'm here to present on regulatory and ethical considerations that we've made along the way for Safe Babies, Safe Moms, and I'll get more into what that initiative is, and hopefully it gives good discussion at the end. So hopefully we have some time for that. So just a quick summary of Safe Babies, Safe Moms. So before diving into that, just want to have this note on inclusivity. You'll see throughout the presentation that you may hear me say women or mothers, but not all birthing individuals identify as women or mothers. And you'll hear that to accurately reflect the current state of the literature, but the approach is meant to be inclusive of all birthing individuals. So Safe Babies, Safe Moms started in April 2020. It's a 5-year initiative slated to end March 2025. It's a $30 million initiative, which represents the largest philanthropic donation in MedStar history, funded by the Clark Foundation. And its goal overall is to reduce disparities in maternal and infant mortality in Washington, D.C. Some key facts from the literature, and you'll see 3 slides at the end with all of my references. So in lieu of putting them on each slide, they're at the end. But women die of pregnancy-related causes at higher rates in D.C. Black women are 3 times more likely to die of pregnancy-related causes than white women, and infant mortality in DC is 27% higher than the national rate. Safe Babies, Safe Moms uses an integrated multi-generational care model, which is the integration of 4 of our key service assets: women and infant services at MedStar Washington Hospital Center, and then from Georgetown University Hospital, we have the Department of Family Medicine, Community Pediatrics, and Child and Adolescent Psychiatry. And then we bring to the table strong community partnerships with Community of Hope, which is a FQHC in DC, delivering care to some of the most vulnerable individuals and populations in the district, as well as Mama Toto Village, which is a wraparound service for birthing individuals in the perinatal space, providing all types of clinical and social supports. And so we look at Safe Babies, Safe Moms through 5 key stages of care delivery: pre-pregnancy, prenatal, delivery, postpartum, immediate postpartum, and then from 0 to 3 years of age. And across each of these time periods, we do social determinants of health screening and referrals, behavioral health screening and referrals, care navigation for those at high risk, and data and analytics. And within each component, we leverage the power of data and analytics as well as clinical expertise to identify individuals, families, babies at high risk. And each of those stages have their own tailored interventions based on that. I won't get into the details of that. So it is primarily a clinical initiative with a very strong research component. So in addition to the clinical leadership that we have leaders from the MedStar Health Research Institute in areas such as implementation science, health equity research, our Center for Biostatistics, Informatics, and Data Science team, human factors, health economics, and that comes from Georgetown McCourt School of Public Policy, as well as historically MHRI. So, and the goal is to make sure that at the end of the 5 years, we really have driven an evidence-based approach and informed the literature on how to reduce these disparities in maternal and child outcomes. So now let's talk about these ethical considerations that we've kind of had to make. So our original proposal to the Clark Foundation, we had our long-term outcomes that we articulated as well as short-term outcomes. And these were created circa December 2019 before the initiative started. And so these were the outcomes we originally slated out to address. The long-term outcome does not change: reduce maternal and infant mortality rates in DC. And then you see our short-term outcomes: reduce low birth weight rates, preterm birth rates, maternal hypertension, maternal diabetes, nulliparous cesarean birth rates, which just means you had a cesarean on your first pregnancy, obesity at delivery rates, postpartum readmissions, and increased breastfeeding rates. And so that was our original approach. And then I think that's going the wrong way. And then we had some insights after implementing this in year one. So what was some of the progress we made in year one? Integration. We had to integrate those clinical service lines that I talked about, understanding the landscape of maternal health and child health overall, the landscape of DC, the landscape of care delivery, did a lot of that. Identifying and filling some gaps in that first year, really fostering the community collaboration with our community partners, significant staff expansion, expanded services of care delivery, new space in that we were able to identify, leveraging the power of data analytics, et cetera. But here's the thing: in that first year, we learned a lot. We had a lot of insights, and it wasn't just us. The Clark Foundation that supports this initiative also has given money to other organizations in DC, like Children's National Hospital, Sibley Memorial, the Mary Center, and others. And so they call it their Parent-Child Health Initiative. And many of us were having these insights that we felt like all of our original outcome metrics probably should take another look. And for us at MedStar Health, for DC Safe Baby Safe Moms, we took this approach called SAFER: sustainability, acceptability, accountability, accuracy, feasibility, equity, and respect. So getting a little bit into that, this is where we landed, and I'll break down some of those ethical considerations. So as mentioned, the long-term outcome did not change, but our short-term outcomes did change. Now, we have always said that this initiative was to target disparities in adverse maternal and infant outcomes in the district, yet none of our outcomes held us accountable for reducing the disparity gap. And so we felt like it was ethically important for us to make sure we called that out and held ourselves accountable for that. And so now it states that we want to see reductions overall, as well as disparity reductions in low birth weight rates, preterm birth rates, severe maternal morbidity rates, I'll get more into that, nulliparous cesarean birth rates, and postpartum readmissions. So when we look at, digging up a little further, looking at this SAFER outcome, highlighting sustainability, acceptability, and equity, what was happening over this first year? Now, MedStar Health has for a long time been part of what's called this National Perinatal Information Center. And this particular group has a number of organizations that submit their maternal and infant data, and they are able to give us quality metrics, outcome metrics on how we stand on certain outcomes in that perinatal space. And we're able to compare ourselves against other like hospitals, et cetera. And so what was happening in this first year for us is that the conversation and the notoriety and the acceptability of what was coming out of the National Perinatal Information Center was starting to become a national conversation. And one of the big things for us for Safe Baby, Safe Moms is sustainability. Even though the grant itself will end in 2025, our care delivery will not. We ethically will not stand for taking away services that are increasing better health outcomes for our families. And so the sustainability argument is extremely important for us. And if these data points are becoming part of the national conversation, they're becoming acceptable to others that matter, payers, policymakers, et cetera, then it was important for us to align our outcomes and align our metrics with those things that were coming out of the National Perinatal Information System. And so we were able now to come up with a new way to look at our information and stratify by race, look at the disparity gaps. The intent of this slide is not to get into it, but to just show how easy now, looking at reds and greens, we can see where we have some opportunities and where we're doing well. And so some of the safer approach allowed us to do that for a number of indicators. Looking at accountability, feasibility, and respect. So the maternal and health outcomes do not occur in a vacuum. Most of health outcomes, period, are 20% of the care we deliver factor into health outcomes. 40% is estimated is social determinants of health. So it's this complex web of patient and family's health behavior, community and other external factors, and then provider and health systems and care delivery. And so what we were noticing about our other outcomes is that it didn't hold us accountable 100% to the things we knew we can control 100% of the time. And so when we looked at our process metrics, the things that we wanted to measure ourselves in doing, operations, flow, care delivery, we wanted to reassess those so we can hold ourselves accountable 100% of the time. And so we made sure what we put on paper in terms of we're gonna do this and we're gonna do it 100% of the time was feasible. And we felt like that approach also respected the agency, the autonomy and the decision-making of the patient and their families. And so we revised our process metrics to make sure those were metrics that we can control 100% of the time. So here's some examples. Percent of high-risk women referred to a navigator for hypertension education services. We can refer 100% of the time. We can hold ourselves accountable for that. High-risk women receiving tobacco cessation counseling. We can hold ourselves accountable for that. If you're at high risk, and you're in our presence, we can give you that counseling. And so we wanted to make sure all of our metrics have that same element of measurement. And so some of these we're doing great on right now. Some of these we had to create workflows from. And so they're all in different stages. And we felt like we needed to be able to report that to the Clark Foundation as well. So these are just some examples of ethical considerations that we had as we overall were looking at Safe Baby, Safe Moms and being able to execute it. Now I want to get a little bit deeper into what we call a supplemental study that came out of Safe Baby, Safe Moms. Very much so still Safe Baby, Safe Moms, but it's a supplement. It gave us an additional $800,000 and it came from additional insights and ethical considerations that we were seeing along the way. So here's one highlight is that disparities in maternal harm, and you can see that I shifted that wording a little bit, we'll talk about that. Disparities in maternal harm are preventable. And yet Black mothers continue to die unnecessarily. Now, in Mary Ann's introduction to me, you may have heard that I do research in patient safety and health equity. And when I hear that something goes wrong within the walls of a healthcare system and it's preventable, typically patient safety comes to mind. And so I think so looking at Safe Baby, Safe Moms through the lens of patient safety, these additional insights begin to happen. Key literature facts: maternal harm is a major crisis that disproportionately affects Black women. Education is not a protective factor. I remind the team a lot of what we now all affectionately call young, fertile Angela. Young, fertile Angela is me if I was younger, if I was fertile, if I was crazy enough to have another baby. And why that's important is because I wouldn't screen for any social determinants of health. Education is fine for me. Income is fine for me. I wouldn't screen for any adverse health outcomes. I'm relatively healthy. But the fact of the matter is, and I'll show a graph, is that I'm at risk. Despite my 4 degrees, I'm at risk for an adverse child or maternal outcome more than my less than high school educated white counterpart. And so something else is at play there. Another fact, about 60% of maternal deaths and about 90% of severe maternal morbidity events are preventable. And most frequently, they are preventable factors at the hands of provider and healthcare system related factors. Okay. So here's that graph I was talking about. And so it illustrates that this is infant mortality rates. The data is from 2001, 2003. The trends have not changed. And you see that the rate for an African-American woman who graduated from college, circled in green, is 11.5%. But a white woman who did not graduate from high school is at 9.2%. And so we see that education isn't a protective factor. So more key literature facts. There's a narrow focus on severe maternal morbidity and maternal mortality in this field. We'll talk more about that. And then for every mother who dies from childbirth, there are 70 mothers who almost die and suffer from severe maternal morbidity each year. And so the field is doing right by trying to figure out what we can learn from severe maternal morbidity events, but it's just not enough. And I call it the equivalent of investigating only plane crashes that are fatal and those that are not fatal, instead of all things that go wrong in aviation. So let's look at that from a picture standpoint. So in aviation, they have learned over the years is that investigate it all, look at it all. To prevent the plane crash, you have to understand what's happening before the plane crashes. And so they go from a safe flight, if there's an unsafe condition, meaning pretty much only pilots and other aviation staff knew something was off in the flight, but the passengers didn't know. They investigate those. They investigate near misses. Again, only pretty much the aviation staff know that something went wrong, and by the grace of whoever, there was intervention that prevented something from going awry. They investigate those. They also investigate those incidences, maybe too much turbulence, and maybe it did reach the passengers. Maybe someone got a headache, maybe someone got a little airsick, maybe somebody got a bruise. So there was harm that reached the passenger, but the plane didn't crash. So they investigate those. And then they investigate the crashes where there were no fatalities. And then they investigate the crashes where there were fatalities. There's a constant monitoring and a constant investigation of all of these. Patient safety does something similar. It actually adopts the same approach from industries like aviation. And it's becoming increasingly better. It's not near what aviation does, but most healthcare systems, MedStar is one, is on a journey for high reliability, has a strong patient safety program, et cetera. But in the maternal space, it's grossly limited. We tend to focus just on that severe harm, which we call severe maternal morbidity, and on death, which is maternal mortality. And so going more upstream, this is a taxonomy that a lot of patient safety organizations use. They look at what's happening and investigate along each of these different time points, and they get really granular, even more granular than the picture that I showed. And so again, the current literature is really just looking at harm and permanent harm and death, whereas there are a lot of opportunities to go more upstream to understand what's happening before we even get there. Some more key literature facts about patient safety. Existing patient safety surveillance methods have benefits and challenges. Our research, my colleague and I, Dr. Seth Pravat, as well as colleagues at RAND, have found that healthcare staff are significantly more likely to report harm and near-miss events when the patient is white compared to when the patient is Black. This leads to disparities in learning from patient safety events and potentially contributes to disparities in harm. Some more key facts: racism, discrimination, and implicit bias contribute to adverse health outcomes that include adverse maternal outcomes. There was a study called the Giving Voice to Mother study that found that women of color are more likely to experience mistreatment during the perinatal period, being shouted at, scolded, threatened, ignored, or receiving no response to requests for help. There are stereotypes stigmatizing Black motherhood, including assumptions about being single, low income, and having multiple children. So the perinatal space is riddled with things like stereotypes, implicit bias, assumptions, and much more. And we see this in stories. One of the most famous stories is that of Serena Williams, where she went into pregnancy knowing she had a pre-existing condition, and she knew what the signs to look for. And so they began to happen, and she began to speak up about it. But when she spoke up about it, her response wasn't what she expected. I highlighted in red that the nurse thought her pain medicine might be making her confused. Fortunately for Serena Williams, she had the agency to keep speaking up about it, and she ended up having that there was something wrong. But because she had agency to keep speaking up about it, she was able to avert it on her own. But if she died, what will be recorded for her is likely there was a pre-existing condition that led to her death, and not the biases from the nurse that we see. And so this story isn't unique. We hear story after story after story after story of things just like that, even from the patient, or unfortunately from their surviving family members if the patient no longer is here. So including the birthing individual's voice can uncover the role of racism, discrimination, and implicit bias across the full spectrum of maternal harm. And we also wanted to look for ways where it didn't have to be a Serena Williams speaking up, but where could we put the burden on the healthcare system to find systematic ways to remove bias and leveraging expertise like human factors? How can we keep patients safe in a systematic way? So here's some key innovations that came out of our human factors team from other work they've done in the patient safety space. So expertise in using clinical informatics techniques to identify signals in the EHR of unsafe care delivery. Zach Hettinger's work has been amazing at that. And so we wanted to see, are there ways that we can identify signals in the electronic health record for unsafe maternal care delivery? Our data science expertise in analyzing clinic notes in the EHR for tone and sentiment and preventable patient safety events. Alan Fong has been amazing at that. And so we wanted to apply these same techniques to clinical notes from maternal care to uncover the role of differential treatment and biases. As an example, there was a recent article in Health Affairs where they did something similar in COVID-19, looking at the electronic health records of patients with COVID who were of color versus non, and they found differences, significant differences in the tone and sentiment used. Here's an example. There's a difference in saying the patient declined treatment, not so negative sentiment, versus the patient refused treatment, more negative sentiment. So those are the types of things that this analysis is looking for to see if that differs by race. So we decided that we could use these innovative methods to identify some clinical signals and bias signals in the electronic health record. So the hypothesis is that if we incorporate implicit bias training, which is happening more globally in the Safe Baby, Safe Moms program, plus incorporate the voice of the birthing individuals, plus identify some system solutions, we'll be well on the course for a further disparities reduction. So enter this supplemental study. It's the Safe Baby, Safe Moms. We call it for short, the Maternal Taxonomy Supplemental Study, or sometimes we refer to it as the Mother's Voice Study. It's a 15-month, $800,000 interdisciplinary study focused on maternal care at Hospital Center and Georgetown University Hospital with two key phases. Phase one is data collection. Phase two is developing the spectrum taxonomy and a toolkit. And so our first aim is to identify these common themes and signals that contribute to unsafe conditions, hazards, near misses, and other maternal injuries by incorporating the birthing individual's voice in both quantitative and qualitative methods, analyzing patient complaints in our system, looking at these common signals I talked about in the electronic health record, and also using our voluntary occurrence reporting system analysis. You may know the voluntary occurrence reporting system as RO Solutions or our patient safety event management system. It's a system that any of us as MedStar associates, if we see something wrong, we can go in and report that. So we have some reports in the maternal and child health space that we'll be leveraging as well. So just wanted to show you the scales that we'll be using. I referenced the Giving Voice to Mothers study, and these and it has 3 common scales in it that get at some of the things that we've been talking about. And this one is the Mother's Autonomy and Decision-Making Scale, and it's really trying to assess how much were they engaged in decision-making in their care throughout the perinatal space. And so you can see some of the questions on the screen there. Then there's the Mothers on Respect Index, and it's really trying to assess how respected they felt. Did they feel comfortable asking questions? Were their personal preferences and culture respected? Did they feel like they were treated poorly because of demographic factors? Did they feel like they held back from asking questions because the provider seemed rushed, and so on and so forth? And then there's a Mistreatment Index, where if they experience any of the following on the screen, that's considered mistreatment. Privacy not respected, physical privacy violated, being shouted and scolded at, being ignored, physical abuse, and so on and so forth. And so, so those are the instruments under phase 1, plus the other analyses we'll do on patient complaints, EHR signals, et cetera. For aim 2, so that phase 1 is huge data collection, and the goal is to take all of that data from all of those different sources to then figure out what's happening. And let me just say in phase 1, for those folks who score high on any of those surveys, we invite them to a qualitative interview to really understand their story. And I'll get more into what that looks like. And so all of that's part of data collection. We take all of that and we convene a multidisciplinary expertise panel to look at the data and see if we can identify these common themes that speak to what's happening to get us from safe to unsafe, to get us from unsafe to hazards, to get us from hazards to near misses to maternal harm to severe maternal morbidity, and then severe maternal morbidity to maternal mortality. And then hopefully we will be able to develop some suggestions, some tools that healthcare providers can use for ongoing surveillance of common themes and signals with mitigation strategies if we can identify them. So that's the overall goal of the study. These are the different experts that we'll bring to the table for developing those themes in that toolkit. So here are some insights and ethical considerations. So in aim 1 for phase 1, so the data collection phase, choosing the cases and controls was a thing. I'll go more into that. The survey design was a thing, survey invitation, interview invitation criteria, the interview process, informatics, data science, and other data sources. So I'll talk about each of those and some considerations we had to make. So first we had to choose the time period. We chose 2017 to 2019 because we didn't want the pandemic to color the results. And that was for sustainability and other reasons, and acceptability of what we find. We wanted, because of scarce resources, we decided that we focus on those birthing individuals that we knew had an adverse outcome, not death, but more on the severe side. So severe maternal morbidity and postpartum readmissions. There are 2 major considerations in reaching out to these types of cases. One is that would we possibly trigger emotions revisiting the events? Absolutely. And so one of the mitigation strategies that we have is that we embed right there a list of behavioral health and emotional support resources for folks, as well as the ability to reach out to anybody on the study team. The other piece is that there is a chance that some of these cases subsequently got involved in some kind of risk management case, a claim, a lawsuit, et cetera. So we excluded those from the study. Then in choosing the controls, we wanted to have matched controls with a normal birth. And defining normal was a challenge for us, considering something normal. Who says that what's normal? And so we just made some calls. Here was our matching criteria: age, race, insurance, mode of delivery, and we matched in the same time period. And so we were gonna use controls who did not experience a severe maternal morbidity event, no postpartum readmission, delivered an infant 2,500 grams or more as their weight. Anything lower than that is considered low birth weight. Delivered an infant at 37 weeks gestation or more. Anything lower than that is considered preterm. Was not delivered assisted by vacuum and forceps. When there's instrumented delivery, there's usually it's usually considered not normal to have to do that. And then did not have an NICU admission. Moving on to survey design. So it was really important for us to have an electronic means from a resource perspective, but also so that people could do this in the privacy of their own space. That was really important for us. It was really important for us that linkages were established. So when Angela completes her survey and she complains of mistreatment, then we can link that to her electronic health record and see if she had a tone issue. Was there a tone issue in her notes? We can see where her clinical outcomes were, et cetera. So it's really important as we try to really understand across the spectrum what happens, what's her story, but also what does the electronic health record tell us? So that linkages were really important. But it was also important to disclose all types of things, like what they could expect in terms of the questions being sensitive, that they could skip anything that they wanted, that they wouldn't be removed from the study if they decided to skip, that we would link to their data. All types of disclosures were really, really important. We used the scales that you saw me show plus, and the plus is because of some of these ethical considerations. We understand in my broader patient safety and health equity hat, we understand that many healthcare systems are on a journey on accurately collecting race and ethnicity information, and really early in the journey in collecting things like preferred pronouns, sexual orientation, gender identity, and more. And so it was important for us to have a space where they could self-identify, where they could report how they self-identify. And so that was important for us. And then it was also important for us to include questions specifically about any concerns they had about their own safety. That's not really captured in the instruments, and because of what we're trying to do, that was important. And then the scales they zone in on language like your doctor or your midwife, which is fine, but we understand that biases can happen in other interactions with the healthcare system, so we wanted to broaden that language out to also include other healthcare staff. And then again, the ability to skip anything was important because of the sensitivity of what we were asking. In terms of the survey invitation, there were many equity considerations that we had. We needed to have multiple ways to invite. We didn't want lack of access to anything to stand in the way. We tried to use our scarce resources to give everybody the opportunity to participate as much as possible. So starting with, do we have emails available, invites going out way? Do we have phone numbers, cell phone numbers available, text messages going out? And absent any of those working, absent the availability of any of those, mail is also an option with QR codes, those types of things. We learned from COVID that most people do have access to a cell phone, a smartphone, et cetera. Wi-Fi is an issue for a lot of different populations, but we felt like this could potentially work. We also wanted to make sure people had multiple opportunities to opt out, to remove themselves from the study, et cetera. Wanted to maintain that agency, autonomy, and respect of the individuals. And compensation was extremely important for us at the survey space and in the interview space. It's nothing for us as researchers when we say we want to put together a technical expert panel, or we want to have a consultant engaged in our R01 proposal we're writing for us to know we have to pay them. Community voices are expert voices. And so we also need to respect those voices enough to say, I value that voice. I value your time. I value your expertise. And so we're going to compensate you for that. And it was also important what the type of compensation was. It's not equitable to say everybody gets a Target gift card. That's not equitable. That might not be good for me in my situation. For me, I might have food insecurity and I don't have access to a Target in my neighborhood. but having a gift card to the neighborhood giant might make sense. Having a gift card that has cash value because my neighborhood corner store really doesn't have a gift card option, or having an option for cash value because my lights might be turning off soon. Like giving that participant the agency to make a decision was really important for us as well. So we leveraged eTango, which gives that participant the option to choose which type of gift card they like, including the Visa cash equivalent option. So for the interview invitation, those who scored not so well on autonomy, respect, and treatment are those we will invite for a survey, whether they were a case or control. If they scored adversely on any of those, we invite for an interview. And it's an in the moment invitation where they can opt out and they can opt in for additional information or opt in right away to the survey, to the interview, and schedule that. And that was important for us as well. Going into the interview process, I think this is where a lot of considerations came in for us. So the study itself is really one of the hearts of the study is the voice of the individual. And so it was important for us that we get their perspective in this story, that while we create an interview guide and while we as researchers have things we want to see about and hear about, we need to start with them just telling their story. And there's value from a research perspective in just hearing the things that stand out from someone's experience. And so Angela may talk more about her prenatal care than her delivery. And that's important. That's an important finding there. So it was really important for us to design this particular piece so that their version of their story, the story comes out. Then with careful balance, with experience, other significant events that researchers care about, trying to get at them without being leading. So this one is a really delicate one that we're really having real significant conversations on. Major credit to Dr. Deb Perry at Georgetown University, Dr. Carrie Sutton at a Center for Health Equity Research, and really giving real tremendous thought to this. And then interviewer selection was really important. The sensitivity of the topic, wanted people with expertise, with lived experience, relatability on a lot of demographic factors, et cetera. And so that was important. And then emotional support considerations, not just for the interviewee, but also for the interviewer. Some of the stories, we anticipate that some of the stories being told, especially because the interviewers are those with lived experiences, can be triggering for them as well. And so having emotional support for both interviewee and interviewer is important. And I've already talked about the importance of compensation. But it also was really important for us from an acceptability standpoint, as well as understanding that people's stories, they can be skewed, that we have multiple perspectives involved in the story, so we can get a well-rounded view. So, and then also in the story, in the study was something that's a little bit more scalable. It's resource intense to survey and interview patients. And so signals are likely in the EHR probably are more scalable, systematic ways of flagging signals. And this shifts the burden from the patient, from having to say, hey, something went wrong, let me tell my story, listen to my story, to the healthcare system in keeping the patients safe. And so I like to, in the nutshell, talk about my desired state is that we can keep patients safe, birthing individuals, families, babies safe, despite a provider who is just determined to have biases, determined to be discriminatory. That's my desired state, is that our systems are such that we too, in somebody who faces that kind of provider, we can keep them safe. And so again, reiterating, what are those opportunities to remove systematic ways to remove biases, leveraging the expertise of human factors and patient safety experts. And so here are all of my references. That is a study that is underway. We're really excited about that. We've gone through the IRB process for the survey part, still developing that interview guide for the qualitative part. but wanted to share a lot of the ethical considerations that we have. Here's some more references. Feel free to reach out to me if you just want the full list or some of these. But I'll stop there and open the floor for any questions and discussion. I believe we have a few minutes for that.
So Angela, two questions came in the chat. The first one is, can you talk on stress in relation association with maternal and pregnancy outcomes, for example, preterm and low birth weight?
Sure. So there is, I talk about this a couple of ways. So there's a researcher, her name is Dr. Arlene Geronimus. She's at University of Michigan, and she has a pretty famous hypothesis called the weathering hypothesis, which speaks to that very question. And it's, so stress, just in general, stress can increase hypertension. Hypertension increases the risk of preeclampsia and eclampsia. And so we see a lot of that, especially for Black birthing individuals. And so so this weathering hypothesis talks about all of the stress of women and birthing individuals of color, what they experience day to day, compounding or weathering the body so that they show up into pregnancy and the prenatal space kind of already behind the 8 ball when it comes to stress and hypertension, thereby increasing the risk of adverse outcomes like preeclampsia and eclampsia. And so, so stress in pregnancy, as well as stress coming into the pregnancy period, is very important to mitigate.
Thanks, Angela. Another one came in. It looks like it may be a comment question. It says, education is usually used as proxy for income and research. However, when it comes to African-American pregnancy outcomes versus white non-Hispanic women, it is not appropriate since the wealth and incomes are never equal.
Yeah, I think that speaks to one of the points made earlier about how education isn't a protective factor. And I would absolutely agree. Education and income isn't a protective factor. And I think I definitely feel like the equity piece of that is part of it. But also the lived experience of individuals of color despite education and income. So going back to the first question about stress and the weathering hypothesis and daily experiences of microaggressions and racism and discrimination, that happens regardless of your education and income for folks of color. And so when they come to that perinatal space with those compounding effects of the day-to-day living of those types of things, and income and education could be equal, and we still could see differences in outcomes because of that reason. And so you're absolutely right.
So how could we see this presentation again? I do believe it's recorded. So I'll talk to Claudia. I'm sure we can get that to you.
Yeah, I would say that would be my answer.
And another says, not a question, but a comment. What a great presentation. This topic was just discussed on a nursing cruise. Thanks for shedding the light on this topic. So very important.
Well, thank you. I appreciate you guys listening. I look forward to telling you what we find. I'm really excited about that. And I will say that one huge ethical consideration for us as a Safe Baby, Safe Moms team, the broader team, as well as the maternal taxonomy team, is that this is hard stuff. It's complex. There are days where we feel like we have, conquered the world. And there are days where we feel like, oh my goodness, there's so much more to do. But there is this ethical consideration that we all collectively share, that if not us, then who? And so we are in an incredible position to make a difference for so many individuals and families. And so there's an ethical burden to do that and continue the work despite the difficult days, the difficult challenges, the complexities, and we keep moving. So thank you all for this, and I look forward to the results of everything we do.
So two other things, there will be a evaluation at the end. I believe that will be pushed out, and thanks to everybody that attended this. And then Angela, also, how can individuals reach out to you? I'm not sure. Yeah,
Sure.
yep, they say, how can we reach you?
Yeah, you can email me, angela.d.thomas@medstar.net. Maybe when the recording goes out, maybe just include my email information in that as well. But yeah, feel free to reach out. You can find me that way. Georgetown colleagues, I think it's ADT52@georgetown.edu.
Well, thank you so much, Angela. We appreciate this. And like I said, everyone, there will be an evaluation. And then you can also contact me if you need Angela's information. I can send that to you as well. But thanks. Thank you,
Thanks,
Angela.
Marianne. Thank you.